So we go to the another interesting topic, and which has been one of my favorite topics for a long time, which is pediatric lens subluxation. So regarding pediatric lens subluxation, as we all know, it is a non-traumatic and are generally progressive. The patients what we operate for lens subluxation, except the traumatic ones, are progressive. This and mostly they present with high myopia and high astigmatism. So the visual acuity drops as the lens margin approaches the pupillary area. So the choice, the decision, what has to be made is whether we operate or not. If we decide to operate, which we mostly do when the vision has dropped to 618 or less, or most of the cases it is 660 and less, and then the choice is to whether to preserve the bag or not. Those who favor preservation of the bag, the logic is that if we maintain the compartmentalization of the eye, then chances of posterior segment complications in future is much less. So let's go to the surgical options that are available. First option is Ahmad segment with CTR and intraocular lens implantation. And as we see in this video, first, the glow is generally very good. So all of us are used to trypan blue in children, but in these cases, if we use trypan blue, then the red glow will go. So that is most of the time it is avoided, and we start from the non-subluxated area. And here you see a very small opening we have made, and a small anterior capsular axis we have made, and then pulled the lens to the center using capsular hooks. And then the CTR is implanted, and with after hydro procedures, but with the CTR, generally cortical aspiration is difficult. We have to pull a lot. And mostly I would say the first choice in these cases are definitely single piece IOLs rather than a three piece, because of the ease with which it can go inside a small rexus. And in this case, as you see, after the capsular hooks are removed, were removed, the anterior capsular rexus is totally decentered. So at this point, we had to make a nick in the anterior capsular rexus and bring it to a respectable size. And then the scleral pocket is made, and through the scleral pocket, we have to fix the Ahmad segment so that the lens is brought to the center. And difference between Ahmad segment and Sioni ring is that Ahmad segment is little bit more stout than the Sioni ring. So we have to, many times we have to pull the anterior capsular rexus margin anteriorly before inserting it into the bag. It doesn't go beneath the anterior rexus margin very easily. And then the 9-oproline is preferable because again, long term, it will not cut through the sclera, and the chances of resurgery will be much less when we use 9-oproline for scleral fixation. Next surgical option is lens aspiration with Sioni ring and intraocular lens implantation. And first, what happened, many cases, maybe 10, 12 cases I did with Ahmad segment. And then in one case, I landed up with a very horrible complication in that, and the bag was lost. And somehow I could finish that surgery with the Ahmad segment, somehow pulling the anterior segment, anterior capsular margin. So I decided to try Sioni ring in the next case. And first case with Sioni ring was this one, and I was absolutely thrilled by the result. But again, every procedure, as you keep on learning subluxated lens, you cannot replicate it in the same way as every other case. So you face later on, I faced challenges with Sioni ring as well. In this case, as you see, the Sioni ring has been implanted before cortical aspiration, and even the preliminary anchoring of the bag has been done, and after that we did the cortical aspiration. Care has to be taken not to do the final knot in this, because again, in the end, you have to adjust and titrate the knot so that the lens is in the center. So just anchoring was done and cortical aspiration was done. then the ring has to be rotated. This is what I always feared and why I did not do Sioni ring, because during rotation you are again straining the already weak zonules. So slightly tighter knot will help, because in future once it becomes loose, then the lens can get decentered. So initial during surgery it has to be slightly tighter knot so that the other side is visible. And most of these children are operated maybe 8-9 years of age, so we don't do posterior capsulorhexis. That is done with YAG at a later point. Surgical option 3 is only CTR and then fix the bag using CTR as the support. And this was accidental, I would say. It is not a planned surgery. The other eye we did well with only CTR implantation, and in this eye also I had expected that and was not prepared with any of the scleral fixating device like a Sioni ring or Emmett segment. But once the CTR was implanted, and as you can see, and again, choice of ports for CTR implantation is a matter of discussion. As I prefer main port, many people suggest the side ports. And after implantation of the IOL, what I see, posterior capsulorhexis also done in this, but it's grossly decentered. So I had no choice. I just used an inoproline and punctured the capsular bag, used the CTR as the anchor, and one going posterior, one anterior. And when you pull the bag to the center, nicely centered IOL. But the danger is that if you're not careful, the damage to the bag can be irreparable. So this in this case, I got lucky, but it may not be the same in every case. Next is, as I told, first case with CTR was very encouraging. I was so excited that it's a very easy thing to do. But in third or fourth case with, Sioni ring, first case with Sioni ring was very good. But in the third and fourth case, this is what I faced. IOL, the lens is pulled to the center, the rhexis is completed. But and the difference is that this time I did cortical aspiration, and that was again not by design. I just forgot the successful formula I had the last time. And then when after cortical aspiration, when you push the Sioni ring, and this portion going above the anterior rhexis margin, and eventually the whole Sioni ring came into the anterior chamber, it didn't go into the bag. And then difficult manipulation, I kept on manipulating for 15-20 minutes trying to push it in the bag, but it didn't go. So then I decided that I will give one final firm push in the bag and in the opposite rotation in the opposite direction. And if it doesn't go, then I will just explant it and remove the bag and put the child for a scleral fixated IOL later. But I got lucky this time with a firm posterior push and a clockwise direction. I could push the Sioni ring in the bag, and then after that, the IOL was implanted. So this is very important. When you're pushing the device, the posterior push is very important. Otherwise, you will end up. It will end up in the anterior chamber. It will not fit in the bag. And then the lens was implanted. And most of these cases, over a long period of time, the fixation side starts deviating towards the center. So we may have to do a YAG, anterior capsulotomy with YAG also. And another thing, when the case is almost unsalvageable, this is another surgical option we have, which is just do a lensectomy. And if the child is young enough, no primary IOL implantation. If the child is maybe 8 to 10 years old, then we can plan for a scleral fixated IOL in the same setting. I've done 2-3 scleral fixated IOL like this. Using the limbal route itself, the lens is with the cutter, the lens is removed. The whole lens with the anterior with the bag is removed, and the eye is left aphakic for a future secondary IOL implantation. So this is another option that we have with us. And always go beneath the iris. It should be visualized, pulling the eye upwards so that the whole of the lens is removed. And that is important for preventing post-op complications. And since what we discussed, that since the IOL, subluxation of the lens is a progressive disease, so many times these children will end up with the IOL and bag subluxated. And here, in this case, it was an anterior subluxation of the bag. So, but still the one side was well anchored. So for the other side, through the fibrosed capsule, it's a very simple suture. Go posteriorly, nick the capsule, bring it out from the main port. And as you can see, I'll most likely this was bent. The improper bending of the needle was there, so we could not go in very smoothly. And then we had to manipulate it in different directions so that it comes out without causing too much damage to the position of the lens. And same thing, it's brought from the scleral side using the railroad technique, and the lens is anchored. So another critics of these procedures tell that it is a progressive disease and you have fixed the lens towards on one direction only, it will definitely subluxate on the other side. There is a very simple solution to that, and this is what it is. It can be very easily fixed and brought, and the surgical time is also very less. And this is a single piece IOL with a similar situation. And here the difference what is there, that the incision, what the nick what we make in the bag is at the optic haptic junction in a single piece IOL. So if you do it at the optic haptic junction and then bring it, and same procedure will take about 10 to 15 minutes of surgical time, and there it's well centered. So this is how, these are some of the options we have for lens subluxation management. And with this, we finish all on time, and we have 2 minutes for discussion.